So what does this enemy look like? Typically, when we and the literature are discussing glenohumeral arthritis, we're referring to grade 3 and grade 4 chondral pathology, which is chondral loss. These arthritic changes present on a wide clinical spectrum, as exemplified by this photo out of our institution of incidental grade 4 glenoid damage that was found during a posterior labral repair in an 18-year-old. All the way down to these findings of end-stage capsulorrhaphy arthropathy in a 20-year-old and post-traumatic AVN in a 28-year-old female. So although shoulder arthroplasty has reproducible positive outcomes in older patients with primary osteoarthritis, younger patients tend to report inferior outcomes, and radiographic loosening is much more of a concern to us as surgeons. This is likely due to the unwelcomed post-op limitations that we put on these patients and their greater functional expectations at a younger age. So solving the particular dilemma starts with understanding these various etiologies that leads to their shoulder arthritis in the first place, because as I mentioned earlier, the knowledge of what actually is causing the shoulder arthritis helps you determine the pathophysiology, natural history, and can lead us down the optimal treatment algorithm. So let's get into the etiologies themselves. Although shoulder arthritis is often multifactorial, the etiologies can be broken down into primary or secondary, as we know. So primary arthritis, which is not the topic of today, is defined as age-related idiopathic change of the articular surface, typically a response to repetitive mechanical stress. Today, we're focusing more on secondary etiologies, which are much more common in the younger population. These are defined as cartilage damage caused by a known pathologic predisposition. A good visual representation of the etiologic distribution between older and younger patients is seen in Matson's JBJS article from a few years ago. So this showed that a significantly higher rate of patients underwent shoulder arthroplasty for a secondary etiology if under the age of 50 years old, whereas a disproportionate amount of patients older than 50 underwent arthroplasty with primary arthritis. So we're now going to dive into the specifics of each secondary etiology. And first, we're going to discuss the most common, instability arthropathy. So the pathophysiology of instability arthropathy is well depicted in this diagram. This portrays a disruption of the dynamic and static stabilizers of the glenohumeral joint, allowing for increased translation of the humeral head and the glenoid rather than the physiologic rotation that we typically see. What do we know about the prevalence of instability arthropathy after anterior instability events? So the top study shows that the prevalence of moderate to severe radiographic shoulder arthritis in non-op anterior dislocations was 9% in patients under 40. Obviously, this was a very heterogeneous population, so a follow-up study was done, which is the study below, which found a very similar rate, 9.2% of non-operatively treated single anterior dislocators by the age of 30. Instability arthropathy can also present after posterior instability, as we can imagine. So Cameron et al. Reports a 5% rate of instability arthropathy in patients that presented with clinical posterior instability. The average age of this 5% of patients was 35 years. And as we would expect, we do have evidence that recurrent dislocations and chronic instability are associated with a higher rate of radiographic change. So when we're considering traumatic instability with concomitant osteochondral defects, Bankart and Hill-Sachs lesions, this study showed that out of 570 shoulders with a mean age of only 37 years, preoperative radiographic arthritis was significantly associated with these osteochondral lesions. Shifting gears. So we just discussed instability arthropathy, but we should remember that the stabilization procedures themselves can also alter the biomechanics of the shoulder and promote degenerative change. The pathophysiology of this phenomenon is well described in the study here. So they described the over-tensioning of the anterior capsule with these instability procedures, causing a decrease in external rotation, driving the humeral head posteriorly, and increasing the compression forces on the posterior joint surface. As we know, the most notorious of these anterior tensioning procedures that led to early arthritis was the putty plat, where the subscap myotendinous junction was divided and functionally shortened in order to tighten the anterior glenohumeral joint. However, this procedure was abandoned around the 1980s, and patients affected by this side effect may present less frequently over time from this talk. Shifting gears again, traumatic osteonecrosis. Moving on to this, we know that fractures occur in all age groups, making young adults susceptible to their negative consequences. Traumatic osteonecrosis, or AVN, occurs when the blood supply to the articular surface is compromised, leading to subchondral collapse. Although more common in skeletally mature patients, there are many reports in the literature of traumatic AVN in patients with open physes. I put this example of a 16-year-old after a Salter-Harris 3 proximal humerus fracture in order to help you see this. But a more generalizable study to our topic can be found here. So this retrospective review of 154 proximal humerus fractures had similar rates of AVN in patients older and younger than 60. This does provide evidence that younger adults than 60 are not immune to this potential outcome. And as we know these details, but it's worth mentioning, the non-modifiable risk factors for traumatic AVN include near 3 and 4 part fractures, as well as a posterior medial metaphyseal extension, less than 8 millimeters from the head fragment, and disruption of the medial hinge. So in a different vein, osteonecrosis can also have an atraumatic pathogenesis, in which somehow the blood flow to the articular surface and subchondral bone is compromised by means other than trauma. Atraumatic AVN affects males twice as much as females, just as in the hip, and most patients typically become symptomatic as early as the 2nd to 5th decades of life. Known risk factors for AVN include a history of chemo, radiation to the ipsilateral shoulder, lupus, sickle cell disease, alcohol abuse, and any disease that requires chronic steroid use. The disease can be classified based on the CRU classification, which is important to know because this can help lead us down the correct treatment algorithm. 1 indicates no radiographic change, 2 mottled sclerosis, but the head maintains its curvature, 3 indicates subchondral fractures on AP radiographs, 4 subchondral collapse and loss of sphericity of the head, and 5 indicates glenoid involvement. It's important to recognize that osteonecrosis is commonly progressive. So the clinical course was well defined in this study. They followed 65 atraumatic AVN shoulders, atraumatic, for at least 2 years. They found that stage 3 disease or greater and any sign of stage progression over the 1.5 years they followed was associated with poor patient-reported outcomes. To the next etiology, we're going to discuss septic arthritis. So in this arthroscopic photo, you can see the irreversible grade 4 chondral damage that occurred with delayed treatment of the septic shoulder in a young adult. Staph is the most common infectious organism in septic shoulders. This review of 23 septic shoulders showed that 70% grew staph and 17% of those were MRSA. In this talk, I wanted to go over the widely accepted theories of how staph inflicts its chondral damage. There's 2 components to this. 1 is the immune response of the host promotes migration of proteases, cytokines into the synovial fluid to help kill the bacteria, but this inadvertently attacks the chondrocytes as well. And secondly, specific to staph, they produce alpha hemolysin, which is an enzyme produced by the staph that preferentially attacks chondrocytes. Now to rheumatoid arthritis, which could be an hour talk within itself, but we'll briefly go over it. This is often diagnosed in young females between the 2nd and 5th decades of life. Specific to the shoulder, studies have shown that rheumatoid arthritis have been associated with a 45% rate of bilateral radiographic erosion within only 5 years of diagnosis, and this study was performed before DMARDs were readily available. This study classified radiographic shoulder rheumatoid arthritis into 3 patterns: concentric, upper migration, and destructive. We typically see the concentric and upper migration as less aggressive patterns that present in older individuals. The destructive pattern is what we're going to see in younger individuals. In this study, they had a mean age of 47. The destructive pattern is going to be characterized by randomly distributed lesions of the humeral head and glenoid, as in the images from the study that I added here. All that being said, modern treatment paradigms centered around disease-modifying antirheumatic agents, or DMARDs, have given us the potential to halt rheumatoid progression in the shoulder in younger patients. This is evident in a 2018 study that found that the number of patients undergoing total shoulder arthroplasty with a diagnosis of rheumatoid decreased by 50% between 2002 and 2012. This study, more importantly to this topic, showed that the patients that underwent total shoulder arthroplasty in 2012 were significantly younger than in 2002 were significantly younger than in 2012, indicating that patients are developing end-stage rheumatoid at a later date currently. So in light of this evidence, we can expect fewer young patients to present with shoulder arthritis secondary to rheumatoid in the future. And next, another predisposing risk factor to shoulder arthritis is glenoid hypoplasia or dysplasia. This is developmental pathology characterized by posterior inferior deficiency of the glenoid and scapular neck. Although it's commonly found in isolation, it is also commonly associated with syndromes ranging from mucopolysaccharidoses, skeletal dysplasias, chromosomal abnormalities, and birth palsies. Historically thought to be a very rare condition, 2 recent studies evaluated advanced axial imaging of all patients at their institution that presented with shoulder pain. They found that the prevalence of GD on axial imaging for any patient with shoulder pain was actually 14 to 18%. Although the exact natural history has not been established, GD is thought to predispose patients to early osteoarthritis because the abnormal glenoid structure allows static posterior subluxation of the humeral head, posterior glenohumeral instability, which increases the translational forces and posterior peak pressures at focal points on the articular surface. Moving on to the next etiology, neuropathic osteoarthropathy of the shoulder, or Charcot shoulder. This is a very rare condition that can cause early arthritis in the young adult. Although commonly a sequelae of uncontrolled diabetes, tertiary syphilis, or other peripheral nerve disorder in elderly patients, Charcot shoulder is most commonly associated with cervical spine lesions or cervical cord disorders, such as the syrinx in younger patients. And in the literature, these typically present within the 2nd and 4th decades of life. 2 theories behind the pathophysiology of neuropathic shoulder arthropathy are, as expected, 1, the joint erosion is secondary to repetitive trauma that is on an insensate joint. But more interestingly is 2, there's a neurally mediated hyperemia and osteoclastic overactivity that leads to excessive bone resorption in these patients. So until now in this talk, we've gone over capsulorophy arthropathy, which we focused on, and then focused on developmental, infectious, and traumatic etiologies of arthritis in the young patient. But let's now transition to etiologies that we as the surgeons can help prevent or avoid other than suture capsulorophy arthropathy. So the first, which is the most obvious, is iatrogenic intra-articular hardware. So screw malposition or protrusion intraoperatively is much more common than cutout in young patients because they have healthy bone. But it's important to recognize that the cutout rate for all comer proximal humerus fractures in the most recent systematic review of the literature was 7.5%. So you can't always rule this out. Metallic anchors and staples used around the glenohumeral joint are more of a historical purpose, but there are patients floating around with those today. They can become intra-articular loose bodies and lead to significant early arthrosis. In this case series of 8 patients, 2 of the patients in their 20s actually developed such severe arthritis that they had to go into total shoulder arthroplasty after 2 metallic anchors became loose. Interestingly, intra-articular pain pumps, which were introduced in 2004 for post-op pain control, have been significantly linked to acute severe irreversible post-operative chondrolysis. Not long after they debuted, reports of early glenohumeral chondrolysis and arthritic change were reported. This is a JBJS Systemic Review article that went as far as to claim a causation between chondrolysis and these pain pumps, which is pretty rare to do in the literature these days. The results of this review not only demonstrate a relationship between the use of these pumps and chondrolysis, but they also were the first to find that a higher flow rate and higher concentration of the anesthetic bupivacaine was actually associated with a higher rate of chondrolysis. In 2011, the FDA issued a warning against these pain pumps. Lawsuits had been filed, therefore overall they had fallen out of favor in use. But it is not unlikely that we'll continue to see young patients who sustain these iatrogenic injuries present to our clinics over the next few years. Moving on to the next etiology, thermal capsulorrhaphy. So this is a procedure that has also been shown to cause early chondrolysis and rapidly progressive degenerative changes in the young adult. Introduced in the 1990s, thermal capsulorrhaphy was used as a capsular shrinkage procedure for the treatment of instability, where the intra-articular soft tissues were heated to at least 65 degrees Celsius in order to induce collagen reorganization. Not long after this debuted, numerous reports of suboptimal outcomes and significant symptomatic chondrolysis in patients undergoing these thermal capsulorrhaphy procedures began to surface. One of the main outcome studies was out of this institution by Dr. D'Alessandro, Fleischle, and Connor. The overall accepted theory that the anticipated benefits of using thermal energy to shrink the capsule was also leading to thermal necrosis of cartilage and direct chondrocyte death. Because of the influx of these negative reports, the editors of Arthroscopy in 2007 published an urgent editorial recommending against the use of this procedure. Although this editorial did occur in 2007, we can assume that younger patients that had this procedure 13 years ago are still afflicted by this negative outcome and may present to us today. And finally, let's end by recognizing the term post-arthroscopic glenohumeral chondrolysis. So PAGCL is terminology commonly found in the literature to describe rapid degenerative changes within months of arthroscopy. It's important to recognize that this is a catch-all term. It's not specific to one etiology or cause, but it actually pertains to a multifactorial phenomenon caused by many variables related to shoulder arthroscopy. The pathology is well demonstrated in this depiction of a 20-year-old patient who underwent an uncomplicated Bankart repair, but that were followed over 1.5 years and found to have rapid chondral death and arthritic changes. Factors that have been deemed potential causes of PAGCL are gentian violet, which is a dye historically used for rotator cuff arthrography, intra-articular pain pumps, as we've already discussed, irrigation fluid with abnormal osmolarity, pre-existing collagen disorders in the patient, and of course, thermal energy from the light source and mechanical damage caused by our arthroscopic instruments placed in and out of the joint. So in summary, it's obvious that the differential here is broad. This is a rare but complex problem when it presents, so it's important to look for the predisposing variable. The pathophysiology can commonly be broken down into 2 scenarios. One, and more commonly, abnormal biomechanics lead to increased focal peak pressures in the posterior joint surface and humeral head. And 2, there's been thermal or chondrotoxic chondrolysis that's occurred in the joint. Thanks, Dr. Connor, Hammond, Mormon, and Saltzman for their input on this talk. I'd be happy to answer any questions.
Great, thank you, Brad. Excellent talk. So I'd offer, Brad, if you could stop sharing your screen, and would recommend everybody goes to gallery view and turn your cameras back on so we can bring our community back together here for a couple of questions. I see Dr. Hammond here, and I'm sure Dr. Saltzman's here somewhere. Everybody's starting to pop up. some people mask, some people not, so I can't identify everybody, but I would love to hear from some of our shoulder and elbow folks comments.
So Brad, this is T, and I'll make an opening comment and question. We've had a lot of controversy over the past several years about recurrent instability in our athletes after dislocations and whether it's really a good idea to fix them early or not. I guess the data is now sort of tipping over to let us believe that this is probably not as benign as we thought before.
Did you freeze, Dr. Mormon?
Oh. Dr. Mormon, we're not ignoring you, but you froze and we can't hear from you anymore.
I know what Dr. Mormon was getting at, though, or I can
Brad, an answer.
Yeah, I can assume what he was going to get at was, is there any new literature about doing instability procedures after a primary dislocation? Because there is new literature coming out that up to a 9 to 35% rate of arthrosis is seen in these patients even after one dislocation event. So it's kind of interesting. We don't know if it's the chicken or the egg, because many of these retrospective studies are radiographic studies performed after they've already undergone anterior tensioning procedures. But I think that the studies are going to get better over the next few years, because we're getting further away from the anterior over-tensioning biomechanical problem that we noticed a few years ago. Pointed out, it was like the 10th slide, that there was a cornerstone study showing that recurrent dislocations leads to a higher arthrosis rate. But there are many, many studies since 2015 that I found and are not in this talk that make it a point that there is arthrosis occurring after a single instability event. So I don't think it's my place to say if we should fix these after one instability event, but there is evidence that's pointing in that direction.
Brad, Pat Connor here. Great job, great review, very comprehensive. I think you hit on it. A lot of the studies in the past and on some of these modifiable factors, such as when to repair an unstable shoulder, hard intra-articular hardware, et cetera, are things that we really need to focus on. And I really don't have much to add as such a comprehensive review, with one exception, and that is there's been growing evidence that would suggest that an acute traumatic posterior labral disruption or avulsion, particularly in athletes, that goes untreated, can lead to, in a much higher percentage than we thought in the past, a very rapid deterioration for all the biomechanical reasons that you've outlined. The historical studies on posterior subluxation have had less instability, we feel, because those studies have not been able to accurately diagnose the injury as opposed to an anterior dislocation that's obvious. And so some of the prospective studies that have MRI involvement are showing that we should probably be more aggressive on these acute posterior labral disruptions, particularly in young athletes that are going to continue with posterior shear forces across their shoulders with working out, particularly linemen, people that are doing a lot of bench press, anything that's putting a posterior shear on their shoulder. So a great review, and I look forward to your next talk about treatment options so you can teach us how to treat all these young arthritic shoulders.
We'll invite maybe one more comment, because we got to get to our next talk. Dr. Mormon, Brad did do a good job of answering your question. We got it before you froze up there, so he can give you the details of the comments later.
I'll just make a quick comment, guys. I can't agree more with Dr. Connor's comments. The subtle posterior instability can be a real problem and lead to rapid arthritis, and we should be probably more aggressive in treating those and identifying them. The other etiology that's really tricky that gets missed a lot is the dysplastic glenoid in the young adult. Those do lead to arthritis, and as Brad's probably going to mention in his next talk, the treatment algorithms for those types of patients are far different. But many of these patients that present with early arthritis have dysplastic glenoids that you have to really look for, or you'll miss it, and it'll really have implications on how you treat them. But great talk, Brad.
Thank you.
Great. Thanks again, Brad. Appreciate your info today. We will move on to our second talk this morning. Dr. Macnet. Dave, you want to load up here? There we go. Get headed to the top there. Perfect. So apropos to the introduction of our newest research member on the biomechanics side, we'll have hopefully plenty of critical commentary for you, Dave, at the end of your talk. So we're looking forward to hearing from you. So go ahead.
Yeah, that was quite a good timing, I guess, or bad timing, depending on who you're talking to. So today I'll be discussing wearable activity trackers in orthopedics. One thing to keep in mind here is that the cost data that I'll present is based on 2018 values. This is a rapidly evolving field, and in about 15 minutes, it's hard to do a full comprehensive review, so I do not pretend to do that. So an activity tracker in general is a broad term. Where it is worn, which type of data it collects, how it records data vary greatly between the different activity tracker categories. There's a big difference in the commercial use, like what we think of with Apple Watches or Garmin's, and what is used in research. Currently, it is estimated that about 21% of the population owns an activity tracker, and of these commercially available types, 95% are worn on the wrist. As we will see, this is very different than what is used in the research world. The use in the research world in general is blossoming, with more and more studies each year utilizing some sort of activity tracker, as you can see from some of the NIH funding statistics here. The mere act of wearing one has been found to increase people's overall activity levels and aid in chronic disease management. There are 4 basic categories that activity trackers fall into: pedometers, accelerometers, heart rate monitors, and combination products, and we'll go through each here. The pedometer is the most simple and inexpensive, and it has the longest track record in research. It is worn in the central axis of the patient, typically around the waist or belt, as you can see depicted here. They are uniaxial, meaning they only detect acceleration in a single plane. In this case, the vertical plane, and each vertical oscillation of the hip triggers a mechanical sensor to record a step. Benefits of the pedometer include its costs, the fact that there's no protected health information stored, but drawbacks include its inaccuracies at low rates of speed, like walking speed, and it can be inaccurate in people using assistance devices for ambulation. Accelerometers are a step up. They measure acceleration triaxially, which allows for more types of activities to be detected and metabolic cost estimates to be generated when patient or user specific factors are input, like age, sex, height, weight. These 2 are generally worn on the waist or via a chest strap on the central axis. They are slightly more expensive, but have a growing use in research based on its improved data generated to cost ratio. And the CSA actigraph is the most widely used in research. And there's heart rate monitors, which do just that. And these are kind of a completely different field of data generation. They're better at measuring metabolic costs at different levels of activity. Additionally, heart rate monitors include the ability to store its own data, which makes data retrieval easier. The basic type is worn as a chest strap, as depicted in the lower image here. It detects heart rate, heart's electrical signal via 2 electrodes. The cost of one step is not equal for all patients. That's why a heart rate monitor can be a better calculator of energy expenditure. And the Polar Electro Company is the most widely used in medical field and research field. They have validated alternatives to EKG and Holter monitors. But as you can see, the price for these is a slight step up. The combination products are less widely used in research due to validity, patient healthcare concern, healthcare information concerns, and reliability. But they're more commonly what we think of in the commercial design. These combinations include heart rate monitoring, accelerometers via gyroscopes, and possible other physiologic sensors. They can be worn in a variety of body locations, have their own mobile applications for data display, but have the least amount of published literature on them. The question that I had coming into this is why aren't combination products like the wrist-based activity trackers the standard in research? They're easy to use, they have clean outputs, and are reasonably priced. And the answer, as I briefly noted, is in the reliability. Central monitors worn on the chest or waist are simply much better in terms of data accuracy when compared to the peripheral monitors like those worn on the wrist or the ankle. One problem that has come up with accuracy in research is the ability to detect steps at low rates of walking speed, which is very device dependent. As you can see here, the Apple Watch actually does a poor job of this versus the Garmin and Fitbit devices. There's currently limited data in the use of these devices with assistance devices for ambulation, which may hinder some of the orthopedic uses. Most of the research that has been published are on validity-based studies looking at specific types of activity trackers. When looking at the entire body of research, the published studies in orthopedic is relatively low. Current applications for orthopedics are as followed. Most commonly to determine the post-op treatment trajectory of a specific injury or surgery. For example, how quickly are patients meeting their preoperative function after like a total knee arthroplasty? An interesting application will be how they can replace formal gait labs. Instead of measuring mobility, like in our mobility toolkit used in the trauma world, these devices are better at free living analysis, like how people are truly doing in their day-to-day lives, not just an in-lab test. Their interrelationship with patient-reported outcomes as an objective measure to correlate with subjective patient scores will be interesting. Their measurements may allow us to detect complications sooner by detecting a dip in patient activity. By detecting normal loads that the body is subjected to, we may be able to better extrapolate this to our cyclic loading in vitro studies. An exciting new development that I'll discuss further is how it's being used in sports medicine. And as we've seen recently with COVID stuff, this may have an impact on how we work with telemedicine in the future. So this telemedicine-based approach with activity trackers has been successfully utilized in the general oncology literature to monitor patient activity levels and aid clinicians in guiding patient decisions. This has a potential for us to reduce the number of office visits a patient may have to undergo. For example, if they're hitting specific activity-based metrics, like number of steps or distance traveled per day on foot after a total hip, for instance, we know that these patients are doing well and they may not necessarily need another visit. Likewise, as noted before, a decrease or decline in activity may detect a need for more physical therapy or a possible complication. If we have data on what a normal patient trajectory is and data on what has been shown to be successful, we could give patients specific metrics to hit. And physical therapists could also use this to monitor their patients from afar. So I'd like to highlight a few studies and a few uses in orthopedics. There are two spine studies which I would like to highlight as an example. This first one is out of Korea using Fitbit monitoring in patients following lumbar laminectomy to monitor activity and correlate it with patient-reported outcomes. They found that the mean number of steps taken post-operatively was negatively correlated with VAS pain scores and positively correlated with ODIs, meaning that the patients who were more active have better functional scores and less pain, which I think we can agree is intuitive. The second study looked at both cervical and spinal operative pathologies in 30 patients using an accelerometer. They recorded preoperative step count and compared to this their postoperative course, and you can see a gradual upward trajectory as the weeks increased. Just like has been found with patient-reported outcomes, patients with depression had lower functional scores postoperatively and had slower overall postoperative trajectory. There are two recent and ongoing studies in the total joint literature. The first one here was a RCT of 163 patients undergoing total joint arthroplasty. They measured patients preoperatively for 2 weeks at baseline. They then divided the patients into two groups. The first group could see their daily data in step count and was given a step count goal, while the second group was not given any sort of feedback and could not see their step count. The patients who received the feedback from their device and had goals showed significantly higher activity levels at all time points postoperatively. This would have the potential to accelerate patient rehab without any additional physician or physical therapy input. There's currently a randomized control trial going on with Zimmer and a collaboration with a new Apple Watch platform called My Mobility. They are following total joint patients longitudinally with the aim to use the watch as a motivational tool in the rehab process. From this data, we'll also be able to define normal postoperative trajectories and possible trajectories for patients with complications. As I mentioned before, free living activity analysis may be a better tool that in-person based metrics like the time get up and go test are not maybe that great at measuring. The accelerometers have the ability to generate gait analysis data without the use of optical sensors. You can collect data like walking speed, cadence, stride length, among others. The development of gait analysis in real life conditions like on uneven terrain can provide us with insights regarding the quality of gait that traditional in-lab based tests simply can't measure. Studies have used activity trackers and their protocols to measure postoperative functional data, are finding the data to be more objective and reliable than patient-reported outcome measures. Similar to computer-adapted testing, there may also be less of a ceiling effect. In vitro studies are using postoperative mobility data to estimate loads that a construct would need to tolerate with early mobilization and can apply this to their cyclic loading conditions. Here are two foot and ankle tendon-based studies that have looked at just that using data that has been gleaned from activity tracker studies. The use in sports is an exciting, rapidly evolving use in orthopedics and sports medicine in general. I'd like to thank Norm Waldrop, one of the physicians at Alabama, who was a big resource in putting together these slides for me. At Alabama and across many of the pro and collegiate levels, GPS and accelerometer data is being constantly collected on all their players. And output metrics include peak velocity and change of direction speeds, as well as a host of many others like total distance traveled and total steps taken at practice, etc. These are worn on their shoulder pads as kind of depicted above. And this allows the team to manage player load in a new way and also guide post-injury rehab and return to sport. Dr. Waldrop and the Alabama team noted a decrease in the amount of soft tissue injuries like quad and hamstring pulls when they began using this data to manage their players' load. This graphic here shows the data from a patient before and after an injury, where the vertical axis represents peak velocities and deceleration speeds, and the horizontal axis shows side-to-side accelerations. The larger green and gray diamond is representative of the patient's pre-left ankle injury, and then the inner diamond, red and gray, is a patient immediately after a injury. As you can see, his peak deceleration decreased, and this was a left ankle injury, so his right side accelerations were markedly decreased. And then this lower graphic, you can see the patient pre-injury velocity and distance traveled, And then following the injury, you can see that the peak acceleration distance travel decreased and then increased in the post-operative period or post-injury period. And we could use this data to potentially guide when a patient can successfully return to sport. There are a ton of devices currently being used in the literature, and we need to further studies showing us which are the most reliable without industry funding. This will be helpful when we are comparing study to study with different activity trackers. There are limited studies currently in the pediatric population, and we don't know how this will correlate with their patient-reported outcomes. As I highlighted, I think these devices are huge potential future application in telemedicine, especially in tertiary referral centers like ours, where patients may travel from very far. I could also imagine this being useful in the workers' compensation world to get a better idea of how patients are functioning in free living conditions versus, a functional capacity examination. One major thing that will need to be addressed is how to manage protected health information. Many of the commercially available devices require the users to accept data sharing agreements, including personal information, and this is usually unknowing to us. That concludes my talk, and open it up for discussion.
Thanks, Dave. That's great. Nice to see a virtual cameo from Dr. Waldrop, one of our alumni. So if everybody could pop their cameras back on, and we will look for some comments. Would certainly love to hear from Dr. Sell and Ryan and any of our other clinicians who have used various wearables in some of their research. Certainly this is an evolving area of interest in research with unlimited potential.
I'll start. So that was a really good overview of sensors and activity trackers, and it's been an emerging field for probably the last 3 years, and there are a lot of issues with reliability and validity that we have to understand. But the idea, over the last 2 or 3 months, the emergence and the necessity of telemedicine, I think, is going to drive some of these capabilities and usage. But there's just a lot of caution about how we use these data with regard to care and treatment. But it can be very valuable, especially in sports medicine research, where we're looking at how much time are they up and moving compared to patient-reported outcomes. There's a lot of concern about when someone has ACL reconstruction and they're returning to sport and returning to competition. Are they loading enough? In sports medicine research, there's the acute to chronic workload ratio, which has gotten so much attention across the world, from rugby to and other sports. But there's a lot of issues with that workload ratio. There's a publication out looking at the kind of data analysis techniques and the issues related to that. But this is an emerging field that I think will be very valuable in the months and years to come, relative to return to sport, return to competition, and recovery and rehabilitation.
So, Dave, that's a great talk. Norm Waldrop is working closely with Lyle Kane, and Lyle's been under a lot of pressure there from a coach that you may have heard of, who is relatively skeptical about medical evaluations. He feels like his return to play criteria, which is that after 4 months you should be able to play after an ACL, is there. So Lyle has actually been able to use the graphics that came out of Catapult that I think Norm was involved in to show Saban why somebody's not quite ready to play yet. And I know Pat Connor probably deals with these same pressures with our coaching staff. So Pat, maybe you have some experience like Lyle's and how to use these things to fend off some of these coaches that think they know when they're ready to go.
Well, I think it's really an interesting and exploding market. The whole concept of sports science, and this is kind of in the very center of that. Dave, great job with your review. I would say not only is the accuracy of these really important, but also we got to get a ton of normative data and a ton of baseline data to know what's important numbers, what's not important numbers, and try to work through that. I will say anecdotally, pretty much every NFL team, I believe, has used these the last few years in their practices and trying to learn more and more. Many are using during the games, but there was one team in particular that is very vocal about not using them. Happens to be the Kansas City Chiefs, who won the Super Bowl last year. So whether or not they're critical or important over time, I think time will tell. But it's an interesting ride. It will be an interesting ride.
Dave, one thing that's coming that we're excited about is smart braces. So they're putting these sensors in the braces that are being used for rehab. And these are particularly helpful as insurance companies are cutting back on allowed visits. And some of these folks that we do the bone, tendon, bone grafts on that tend to get stiff, you know, you can get a readout to your therapist, your athletic trainer, or yourself, your PA, whoever's following your patients the closest, with alarms set the way you want them to be. So we're excited to try that. I know Pat and Jim Flashley and Dana are going to be working on the beta testing of that product. But one thing that's coming that's along the lines of the wearables.
Yeah, and I would add to Dr. Mormon's comments regarding that. Our colleague at Duke, Dr. Bill Garrett, did a lot of work with bracing and in installing accelerometers in the braces to look at return to sport following ACL reconstruction and looking at kinematics and loading and actually just usage of the brace. So is the patient wearing the brace when they're supposed to, or are they not wearing the brace? And then eventually the idea would be if it's a return to sport brace and a brace they want to wear during competition, what can we learn about in-game kinematics and loading?
Great. All right. Well, we are, any last questions, looking for any hands raised or comments? Dave, great talk, great emerging technology that we're all, I think, hopefully going to be at the leading edge of this nationally and maybe even internationally and how we use this. Thanks to everybody for joining in today. It was some great discussions. It's definitely nice to see everybody's faces up on the same computer. Almost makes it feel like we're in the same room. We will look forward to our next grand rounds with all of us together on a Thursday morning. Again, is going to be in 2 weeks. And on that day, we're going to be hearing from our sports and foot and ankle fellows as they do their end of year research presentations. We're getting that agenda together, and we'll look forward to hearing from all of them on that day. And again, if you will receive an email this week telling you where to be for the pictures, don't feel excluded. It is primarily going to be residents with a focus on the chief residents. We're still working on logistics and legalities in that regard. So thanks to everybody again. Look forward to all of this. Hope everybody has a good work day and subsequently a nice relaxing weekend this weekend. So thanks to everyone and take care.
Residents, jump on the other Zoom call for me, okay?
Yes. Thanks, Brian. Sorry.